Give people one more minute to log on and we'll begin. Well, good afternoon, everyone. Thank you so much for joining. I'm Dr. Cynthia Ambrose, and I'm the Chief Medical Officer of Kate Farms, and I'm here today with Dr. Mia Finkelstein. Dr. Finkelstein is the Medical Director of Amwell Medical Group, and Amwell is one of the largest telemedicine organizations in the country, with over 150 million covered lives, dealing with Blue Cross companies, United Health companies, so patients can be covered, and working with doctors to improve their ability to do virtual visits. Dr. Finkelstein herself has done over 20,000 visits, so we have quite an expert. We could use the word expert, I think, today, over her over 7 years with doing this. And she is board certified in family medicine, was formerly a MedStar physician with MedStar Physician Partners in Maryland, and has quite a wonderful background and interest in all sorts of things, but women's health and sports nutrition and wellness. And then I noted in her wonderful background and bio that she's also been an assistant coach in field hockey, basketball, and lacrosse. So I found that very interesting. So definitely the sports nutrition thing is there for Mia. So Mia, just want to thank you. Thank you so much for being here today.
Thanks for that wonderful welcome, Cynthia, and I'm really thrilled to be here. I can talk about anything telemedicine for a long time, so you may have to cut me off.
Well, it came to my attention and came to our attention at Kate Farms that a number of our providers were very new to telemedicine, and they were sort of wondering what their skills really were. I mean, they were sort of kind of hobbling through. Some people actually use that word with me. They were hobbling through being online with patients and feeling like a little unsure of the format and of the opportunities. And so I thought it would really be helpful to bring you in and talk about what we can do to make the virtual visit its best, right? How can we make it the most robust? What are some of the tips that you might have? And I thought we might start out with kind of how you started in telemedicine yourself, what made you, sort of drove you to that, and, sort of how it's built from there for you.
Sure. Okay, absolutely. Well, as you said, Cynthia, I've been practicing medicine for over 20 years, and I started off in a pretty busy city practice, and then eventually moved to a more rural area where I was with eventually MedStar. It was just me and another gentleman for a number of years in a small town. We had a really nice community medicine practice, as many of you have probably experienced at some point. And then we weren't making money, of course, at the time. I loved what I did, and I still do. And I could balance it well with the coaching in our local high school. I was able to be flexible enough with work, which was fantastic, to coach the sports you mentioned, my kids included. I'm also a mother, so I feel that that's my other full-time job, and I have 3 children. And so the practice was going really well, but we weren't making money, which is, I think, the story for many primary care practices. And we allowed a larger health system, MedStar Health, to come on down and buy our practice. When they came in, it was around the same time as EMRs. So there were 4 of us at the time, 2 physicians, a physician assistant, 2 physicians assistants with us. And we learned the EMR, not begrudgingly. We were all like, okay, let's do this thing, and got through it. And then after a couple of years, I started noticing a bit of a pattern that my practice was changing, not by my choice, but we weren't having those same day visits, those slots in there anymore. And I was seeing a lot of new patients when I felt that my panel was already full, and some of these themes are probably resonating with people in the audience. And I also noticed that my geriatric population, which really relied on family members to bring them into the practice to be seen. We don't have any public transportation down here. They were going to the ER, and I wasn't being notified either until maybe after the fact. So I finally said, wait, what is going on here? And I spoke with front office staff, spoke with some of my office manager staff, and then the medical director. And it was just their model. They wanted to do it a certain way, and so be it. So I said, you know what? I have a great idea. I've been reading about telemedicine. This is so intriguing. And I think that all started when I was younger. My mother's a physician, and some of her colleagues who are radiologists did a lot of telemedicine, reading radiology reports. My mother always said, as an endocrinologist, it would suit her well when she retires. So I think I always had an interest in it. And I'd been hearing about American Well. This was about the same time that they were really starting in the early 2000s, I guess this is, right? 2010,
Yeah,
2009, maybe. So
fine, yeah.
anyway, they just were not interested at that time. And so I hit a roadblock with them. And I thought at first, let me go ahead and learn about Amwell and also do my brick and mortar practice at the same time. I had a wonderful interaction with the Amwell leadership, just the energy on the phone, and they were interested in me. I was interested in them even more than I thought I would be. And so I tried to overlap the two, but after 3 short months, I said, this is, I'm all in. I'm all in with telemedicine. And so I left my brick and mortar practice. Though I will say I still do volunteer in my community when they need help in the, with live patients that I can physically touch. So I still keep my hand in it. But what was really interesting then was we only had 13 states that allowed telemedicine services.
Ah,
And which right, and now that has been such a journey because I was able to see, oh yeah, we added another state, and it didn't happen overnight. I mean, this took a lot from our regulatory board, and we had a legal board that would meet. Now I wasn't included in that, so I'm sure it took a lot more than I'm going to simplify it to, but they had to meet with medical boards, with the leadership in the area, and just make sure people understood we're very conservative. We want to do this. Let's break into your state. And it took a while. And I think the last holdout, I mean, years, was Arkansas. And I want to say that was only about 4 or 5 years ago. So it really, is a process to get all the states on board. And now look at this, all states are offering telemedicine services. Some have little nuances with what they're allowed with their regulations. For instance, phone calls, you can talk to anyone on the phone, but you need video to be able to prescribe in certain states. And those barriers, those regulations have really changed a lot recently, with the COVID pandemic, which we can get to in a minute. But anyway, it's been such a great ride to be involved, and I don't regret it for a second. I love what I do. And I think the thing that keeps me going and so energized by practicing medicine this way is the patients. They are just so grateful. They're just so grateful for the visit, the ease of the visit, the convenience, the fact that it's not upending their whole day. They can bring their kids on to be seen without leaving home when they're sick. I mean, you name it. It really has so many good uses that people are just so grateful. It keeps me going. And of course, the cost is less than an office visit. And in most cases, we can do the same thing.
yes, and it was for me. My experience was that we had areas, and when I was in upstate New York, I was both a chief medical officer on the Blue Cross Blue Shield side as well as of a large hospital system in private practice. So what I noticed was that there were difficulties in reaching certain populations. We had Native American populations that were being underserved. We could sometimes get an internist out to them, but we couldn't get maybe a cardiologist or specialist to them. And I kept saying to myself, well, gee, if they're in with an internist, why couldn't we, through some modality, figure out how to include a specialist in the visit? And so when I started thinking about that, we reached out, and it was my first meeting with Dr. Ido Schoenberg, as you know, your founder, and a
Absolutely.
wonderful doctor himself,
Yeah.
who we met, and we started talking about the need for telemedicine and what could be accomplished, and introduced them to the CEO and the CFO at Blue Cross Blue Shield of Western, Eastern, and Northeastern New York at the time. And this was back 2009, beginning 2010, right? So right when you're talking about a decade ago, where there were a lot of barriers, regulatory barriers, physician barriers too, because physicians weren't sure how to inculcate telemedicine into their practices. So,
Right.
how do I sort of see live patients and also do this? It was very difficult for people to sort of figure it out, and
Sure.
not a lot of support or infrastructure, right, for this. So
Yeah.
people were, as physicians are, a little wary of change and changing their schedules and changing their lives. So it didn't, it was very hard to propel it forward. And it was very upsetting to me because I knew, as you did, as we have patients that can't get out to the doctor very easily. And certainly in upstate New York, you have weather issues. I'm in Los Angeles now, so I don't have those weather issues for patients anymore. But clearly there, elder patients and other patients were unable to get out of the house sometimes, or, if you're there with 3 children, you have to go to the pediatrician. One child has an illness, you have to take them all into the car, and drag everybody to the doctor. So there were so many things that made it clear to me that this would be a wonderful adjunct to clinical practice in person. And yet it was just kind of, like they say, pulling teeth to kind of move it along and get it going. And I remember back there, the Gartner report had said that by 2014, 60 to 70% of all medicine that could be practiced online would be practiced online by 2014. And they were ahead of their time, as were we at Blue Cross and Blue Shield. And probably you thought you were a little bit in the beginning. And now we're in the COVID-19 environment. So obviously a lot has changed, and a lot has changed, hopefully in the healthcare system for the better. We will be looking at preparedness, certainly very different than we do now. We will look at trying to get people to eat better and get their immune systems up to par so that they can fight contagion. And of course, this wonderful opening, I think, for telemedicine, where people can see patients online. So having said that, let's just kind of jump right into some of the thoughts you have about what's the best way to sort of start a visit, to think about, opening up your visit. If you're doing telemedicine, can you give us some tips on how people can do a really, really good, robust visit that really is easy for both patient and provider?
Sure. Oh, I mean, this is what I do every day, right? Yes, I'm happy to help with that. I think it really does start with, though you had mentioned, some of the resistance that physicians have. And let's even bring it back to that core anxiety that you may have of practicing medicine differently. I think that's the first thing doctors have to understand, that this practicing medicine this way is just another way to deliver the care you've been doing so well for years, likely in your brick and mortar practice. It's just through a computer, through a smartphone, through a tablet, whatever it may be, or through the phone, which we've done for years. So have confidence in that. It should in no way compromise the quality of care that you give your patient just because it's through the virtual, technology. It's really exciting and the patients like it. So that's the biggest barrier, is for a patient, or for providers and patients to realize they can still get a very robust visit. It can have the same level of quality, and it can be done. I think doctors, in particular providers, just need to become creative with how they get the information that they would get in the brick and mortar setting. And you're right, they may not be able to get 100%, but they can get pretty darn close. I think there's a lot we can do if you really stop and you use your observational skills, which mine are clearly heightened all the time. You learn so much by watching people virtually, or, however it may be. And listening and really learning how to take a good history if you haven't already. And all the physicians on the call will obviously realize or remember back to med school when we were taught that 90% of your history taking skills or your history taking will give you the diagnosis, and that extra 10%, that's just diagnostics and all. So I think we need to come back to that, because I'd like to say that some of my colleagues over the last few years have started to rely on some of the lab results and the diagnostics before they actually, lay hands on the patient or see the patient. And so we're going back to sort of how primary care medicine really started, which is about a good history, good
That's
physical.
absolutely right. One of my mentors, Dr. Moses Nussbaum at Beth Israel Medical Center, when I was first starting out practicing, used to say, there's going to come a time, Cynthia, where we're in the admission office, we're just going to send everyone to CAT scan, and they'll just be full body CAT scan, and then we'll just admit them. We'll definitely find something, right? But the idea that you said 90% of the diagnosis is in the history, right? It's in the history. And that has become, less and less a part of the interview. And we're in a situation now, and, where people go in, literally the physician talks to them within 3 minutes, they're already hands-on, writing, thinking about prescribing, talking about the meds. And the idea of how is the patient actually doing? What's their mental health like that supports their physical health? What do they eat that supports their physical health? These were not things that were even part of the conversation. And in fact, we weren't even, encouraged to include them as part of the interview, the thing about, what do you eat, until very quickly, and even now, there's a shortage of that, right? So there's an opportunity here that I think is amazing, like you said, to get us back to our roots of how we were taught to really practice medicine, and the reason why we were trained to think kind of algorithmically and think through things is because we were supposed to get inputs that made that structure possible, right? So, here we are now, kind of having gone for full circle.
Yeah, it's like it's a virtual house call of sorts, that's it.
Absolutely.
And to your point about the nutrition, I mean, people can literally take their phones and show you their kitchen, right? Show the refrigerator. Yeah. So, yeah.
Yes. Please, can you just walk through some of the things that you recommend, actually, very specifically for physicians when they're setting up and thinking about what they need to do for their visit?
Of course. So number one, it starts with the mindset. You can do this. You can do this. You may be anxious in the beginning, but that's okay. I guarantee the patient on the other side is anxious at first too, because in all likelihood, it's their first experience with getting care this way. So make them comfortable. I always greet people, as you can tell, the look when that video goes on, I think is very important. And I know my colleagues agree. So the white coat is professional. You may not wear one in your brick and mortar, but I believe that for a virtual visit, it's sort of that universal sign that, okay, there's a professional on the other end. So that's what we train our doctors to do. But however you care to dress, just look professional. Look at my background. It should be non-distracting. You don't want to have piles of books in the back, or a cat walking around or kids screaming. You want the patient to know that you're in a private place. Sometimes I'll even say that, that I'm in my basement, no one's around, depending on how anxious that patient may be on the other side. Give them some reassurance that it's just you and that person. And then greet them all with a smile. When that video goes on, if you're nervous and like not looking at them, they're going to pick up on that, and often they'll be nervous and maybe not as trusting. So you want to gain that confidence. You want them to gain that support in the visit quality as well. Looking right at that dot. That takes a little bit getting used to for those of you who are not in the, let's say, in the acting world or did drama back in high school. But yeah, you want to look at that blue dot or whatever color it is for you, so they have eyes on the patient. Non-distracting, good lighting. Put the lighting in front of you. I have got two lights on the other side of my computer. If it's behind you, you'll look like a silhouette. We call all of this our webside manner, so that the patient feels comfortable when that video turns right on.
I like that, website manner. I like that.
Website manner, right. And again, we were all trained in medicine in particular about let the patient talk. So for our model, we do a lot of urgent care. And the first thing I'll ask is, what brings you in today? This is after I confirm they can hear me, they can see me. I confirm where they're calling from. I have 29 state licenses, and I just will mention right now, with telemedicine rules, you need to see a patient only in the states where you're licensed in. So if someone comes in, let's say from Utah, I don't have a Utah license, I'll have to explain to them, okay, sorry, I'm going to cancel the visit so you're not charged. I want you to come back in, make sure your location has been corrected, and then the doctors who are available will pop up. So confirm their location and then ask them, what brings you in today? And I know we were all taught, do not interrupt that patient, give them at least 90 seconds, which sounds short, but it feels long, to just let it all out. And I will say, with this COVID-19 pandemic, it really is important to let the patients talk. They let them go, and then you can focus. You can focus on the problem at hand, and ask your questions, whatever mnemonic you remember, use that. And I always repeat things to patients as well, just to make sure I'm hearing them correctly. I'm sure you all have your own interviewing technique, but we go over interviewing techniques as well. And then I reconcile their medical health with them, even if they shared it with me ahead of time. Some patients do, some patients don't, because we don't require it for them to see a doctor. We want them to just connect when they want to. So reconcile everything. Do they have a primary care physician that they relate to? Do they have a gynecologist? Are they taking medications for anything? Review the medication list, even over-the-counter stuff, and even PRN medications. Do they have any drug allergies? So we reconcile all of that. And then depending on what they're there to see you for, you can focus in on some of the other social points, smoking histories, et cetera, et cetera. And then we get to the creative part of the physical exam. And again, a lot of what we do is going to be a sort of akin to mimicry. So if I'm seeing someone for a sore throat, for example, it's very easy to orient patients. Do not be nervous about it. But on the webcam, I say things like, I want you to bring your mouth up to the camera. You'll feel like you're kissing your computer. I mean, let them know that they have to get that close. Or if they're on a mobile device, bring the camera right up to their lips and open up, just so you get the right angle. And you would be amazed. Play with it yourself, but the picture quality in these phones is outstanding. And same with the lighting. Often patients do not need extra flashlights or anything. If you want to see something that is like a skin rash, get them in front of a window. Natural light is always best. And if you can't, if you can't see or you can't do what you want to do to get that information that you need to help make a diagnosis, you tell the patient. And a great example of that would be, when I see someone with acute abdomen or abdominal pain, let's say, in my head, I'm already thinking 2 buckets, right? I'm thinking, okay, this is something I can handle online, nausea, vomiting, diarrhea, constipation, run-of-the-mill GI, gastroenteritis, or it's a surgical abdomen. More than likely, it's going to be one of those 2 buckets. So, but I can't lay hands on them. So I want them to, give me an idea where on your quadrant of your belly are you feeling this discomfort? And I actually ask them, is it below the belly button or above the belly button? Is it to the left, the right? Orient them. But based on what they tell you in the history and then the physical, if I can't come up with a good diagnosis, I'll say to them, I need one more bit of information. I really need that blood test, or I really need to feel your belly myself. So you are going to need in-person care. Now, fortunately, that doesn't happen that often. And you can have very, very useful, as I said, high quality visits online. Give patients some guidance, treat them if you feel you know how to treat them, and have them come on back in and see you again. And they don't mind doing that because they want to get better, of course, But you can use it as a triage of sorts, where you'll say, I need to see you in my office tomorrow, or you know what, you've got to go to the ER right away. This is outside of the scope of what we can do safely. So, very.
I just come in for a second and ask you,
Yeah.
in the time of COVID-19, has that recommendation changed at all in terms of where you send them if they do need a physical visit?
It's a perfect question, actually. If it's an emergency, that those 2 buckets are still there: emergency, non-emergency. If it's an emergency, whether they're COVID type symptoms, and they're having respiratory distress in front of you, or it is an acute abdomen that sounds like a hot appendix, they're still going to go to the ED. And what we've done differently in this case is we call, or we have the patient, if someone's there with them, call the ED first to see, do you have a separate door for me to come in because I don't have COVID? Is this, a good time to come in? Do you want me to wait 15 minutes or whatever it is? And if it's a COVID patient, we get involved with those phone calls and let do a sign off of sorts, yeah. So it really, I think it comes down to what makes you feel good in that regard, or as a physician. But yes, to answer your question, we still have that bucket of you've got to go to the emergency room. Now, if there is that bucket of, well, I might want the person to see their primary care physician, but I've just been told that their primary care is not seeing patients, right, then I might be a little, I think collectively as a group, we've had meetings about this, we might be a little more liberal with some of the prescribing we're doing. That doesn't mean we're over prescribing antibiotics. I want to say that we have a very robust quality department that is looking at, overuse of antibiotics, and we really strive to we have a report card of sorts, and we mentor our physicians, and we have that covered, I'd like to say. But we have said, if you are worried that this could lead to something in the next couple of days, don't make the patient come back, especially if we're really busy. Give them a conditional prescription and explain to them when you want them to start it and that sort of thing. Now, things have settled down a little bit for our group. I'm sort of going off track a little bit here, but a month ago, the conversation was different. Our volumes, our waiting times were really, really high. Now we've got so many doctors who have raised their hand and said, I'm in, I want to give this telemedicine a try. Let me get credentialed to practice with Amwell. And that's been fantastic for the management of volumes, and patients aren't waiting as long.
That shift has helped the ERs. My background's emergency medicine. So I'm hearing from my emergency medicine colleagues 2 things about telemedicine. One, it has helped shift the less urgent or non-urgent cases for sure, and people that need to go to their doctor couldn't get a doctor's visit. So they've been very happy that telemedicine has stepped into that void, and also in that handoff that you described. such an important piece where someone is potentially COVID-19 positive, is not aware, but has symptoms or some comorbidities that would drive us to say, okay, this person really should go to an ER or somewhere. And
Yep.
being able to do that handoff, professional to professional, help the patient and guide the patient how best to even present themselves for care.
Absolutely. Yep. And
These
I
are
will say,
invaluable.
oh, very valuable. Yeah. And I think professionally for me as well, I mean, many people who are skeptics of telemedicine will say, oh, I can't work without being in a room with other doctors, with other colleagues. But when I get to interact with the doctors on the phone, or I'm calling a colleague via, maybe it's through, Skyping them or on a cell phone, I'm still getting that connection. And I haven't felt that I've missed that as much as I thought I would, even though they're not in the room with me. I
Yeah.
still have my colleagues, just like you, Cynthia. I know who I can call for when I have nutrition questions now. But I think that, it's really important for doctors to understand that you can still preserve that valid piece of social interaction with other colleagues, for sure.
Right, and we're sort of getting emergency learning around that right now in this situation. But again, I think there's a tremendous opportunity here as we see the expansion of telemedicine because of all the barriers in the past. And one of the barriers that we didn't talk about was the reimbursement barrier. So that was a big issue. There was such a differential between whether or not you saw a patient online or live in your office, and that impeded some physicians to make a transition as well. And so with the change there, we do hope, I think as physicians, that that will not be something that goes back and that we will go forward with people understanding that really what you're paying for with physicians is our cognitive abilities, right? Our
Right.
ability to diagnose, our ability to listen to history for the light bulbs to go on and say, if this, then that. I mean, that's what we're supposed to be paid for, really. It's not, the physical environment in which we're doing that work. So
Exactly. And then also to have that education, keep the people who don't really need to be seen in person. You can educate them, through virtual communication very well. And they don't need to be going in the office and taking up the space and exposing themselves and others to germs. So again, I think there's a lot of that has been learned. And to your point, and you may even know these statistics better than I am, but I do believe the CMS has even allowed, as of now, like 85 or more diagnoses that can get reimbursed for. So I think I'm hoping, right, we're going to see that increase because patients want this now, and providers do as well. But patients know, okay, I've been here and I can get care this way. I don't have to go sit in the waiting room all the time. So yeah.
Yes, that's sitting in the waiting room or, even access to that. And so even for insurers, I used to always think you have patients who are chronically ill that need to now leave their home and go to an office somewhere. And every time you do that, some of them need actual transportation, which also is a cost to them and to the insurer. So, or potentially the hospital, depending on how that patient is covered. So it's a real opportunity here for people to see the ease of this and what cost can actually be taken out of the system, especially with recidivism and people continuously going back and forth to ERs and other places because they can't get into their primary care, or they think maybe their situation is more urgent, or they're sort of, what we used to say in emergency medicine, the worried well. People who are they're really okay, especially in COVID-19. I can only imagine the number of people who have any kind of flu-like symptom who think, oh my goodness, am I hit with now COVID-19? So I look at that. But then for the chronic patients, I have my own aunt. I was on the phone just the other day with her, and she was telling me she's in her late 70s, about to turn 80. And she's on dialysis. And she said, I'm going to dialysis now. Cynthia, I can't tell you how much better the experience is. The doctor comes and visits me on the iPad while I'm sitting in the chair.
Wow.
I have, she's on Cape Barbs, so she drinks her Cape Barbs there in the chair. And she talks to her doctor. And then she says the next day in the follow-up visit, which was before an actual physical visit for her.
Another trip.
Yeah. Calls her up. And she can't drive anymore, so she had to have someone always take her or come to the, a vehicle come to the house and take her. So now he's on the iPad talking to her, and she said she would, every time she had to go to the doctor, become ill, like she would get diarrhea or some other symptom just from anxiety of going to the doctor's office. So imagine like all of those pieces eliminated for patients. So we're only kind of hearing the good news from patients on this.
Honestly, I have that just made me think of two things. There is the capability, within these virtual platforms to have multi-way video feeds. So I have seen, to your point of the, geographic distribution, a parent, a sick parent who is in a remote area, they have their child come on as well. Let's say they live an hour away, but they're the primary caregiver and they're calling at work. They want to see the visit and the provider. And you can three-way that call so that the child sees what you're doing with the parent, and it's incredible. I mean, it's wonderful for the family unit themselves. There's so much less stress when they know, oh yeah, I heard from Dr. Mia that this is what mom's taking now, and this is how we're fine tuning it. Maybe you'll have a few more touch points before you actually bring them into the brick and mortar for a physical visit. So it's a great way to, especially with chronic management that you mentioned, the dialysis patient. What about a diabetic who, may or may not be super compliant, but you want to see them maybe once a month so that we can keep them on track? These visits will be well suited for that.
Yeah, and not a bad thing for Dr. Mia either, because Dr. Mia might get some insight from the daughter or son, right, on the phone that you have not been able to get, information that if the person is becoming perhaps a little forgetful or some other issues, and you're impacted by that, of course, in an interview with a patient. And if you've got a family member that can now come into the visit and be involved in the visit, I mean, it just makes a tremendous difference.
Great point, a great point. And the other thing you mentioned about the person with the anxiety who didn't want to go in the visit, I remember one of my first visits with, a live patient back 7 or so years ago was an asthmatic who had anxiety. And he was a controlled mild asthmatic, but he has a lot of like agoraphobia. He didn't want to engage his video. And I said, oh, we're a video-based, company. But, I'm looking really quickly at the regulations, and I was like, oh, phew, I can still talk to him through the phone, and I can prescribe in this state. So let's continue with the visit. So we developed a relationship, and I had him come back and see me once a month for 3 months. Don't you know, on month 4, he allowed his video to play.
Oh,
It was so great. It was so great. And then I have lost touch with him now, but the point is that he was eventually able to get into his doctor's office. I called the doctor for him because I thought he needed some pulmonary function tests, of course. And I said, can he be your first visit of the day or your first visit in the afternoon? So again, we can work and augment the care that patients get with their doctors, whether they're specialists or primary care physicians, very well this way too, and underscore the importance of those visits.
yeah. So you talked quite a bit about what should be included in the visit. Can you talk about anything that should be avoided in the visit?
Oh, that's a tricky question. Well, I mean, this might sound funny, but I think it's really important. Number one, the patient needs to also respect that this is a visit. So the patient needs to come on and be in a non-distracting area themselves. I've had patients who have tried to connect from moving vehicles as if they could just tell me about their urinary tract symptoms and I would treat them without examining them. So,
Right.
you need to, right. We've also had, not often anymore because there are ways to avoid it, but some inappropriate visits, patients trying to, come on and show us things they shouldn't, or ask for medications that we can't write for online. And of course, there are ways to deal with that on the before a visit even occurs. Also having distracting noises in the background. So the patient needs to, and you might have to facilitate that and say, you know what, I really can't hear you and it's distracting me. Any chance you can move to a more quiet area? And
Yes.
that would get in also to the technology. Both the patient and the provider have to make sure that their connectivity is really good. I mean, there's nothing more frustrating, though temporary, now that I know how to troubleshoot, than losing a connection with a patient when you're halfway through and like you didn't do the physical or you didn't go over the treatment plan. Make sure the patients, are near their Wi-Fi, if their router rather, if they're using Wi-Fi. Make sure that you have a good, I'm hardwired most of the time when I'm seeing patients just to make sure the strength of my signal is good, but make sure the bandwidth is there and that you can see and hear them clearly. Certainly, if you can't see a throat, don't say the throat looks normal on your note. I mean, you want to make sure you're looking at these things and doing right by the patient as well as yourself. So make sure you're not afraid of asking for more than what's in front of you. And so that's something that, you don't want to do. You want to have that confidence that, okay, I need more, or just tell the patient, this isn't going to work through a virtual visit and you are going to need to be seen in person.
How do people respond to that when you say, you can't do the visit this way, or, you're into part of the visit and you see that they do need to be seen? How does that work, and how do patients sort of perceive that and respond to that?
I feel it's really in the delivery. I think the physician, if the physician cannot make a sound diagnosis or at least a differential that can offer some treatment and let the patient stay at home and sort of see what happens with a little watchful waiting and supportive care or whatever treatment it may be. If they really need to be seen in person, the doctor just says, and this is sort of my go-to statement. I'll say telemedicine is great, but we're limited sometimes, and I can't look in your ear to confirm that this is or isn't a middle ear infection. And the look of your child, the fever, they don't usually get ear infections. We really need to see that. And I think parents are really accepting of that. Again, the way you deliver it. If you're saying, oh, no, can't see this, I'm canceling out the visit, good luck. They're not going to like that. It won't be as much of a good visit. They won't want to come back and use telemedicine. So, I have no problem saying that. Another good example is someone comes in with a coughing and a fever, and you're talking to them and realizing, shoot, this person could have pneumonia. I say, listen, I try to get to that point quicker rather than get through a full visit and tell them then. But I'll say, you know what? This already is making me anxious. And even if I saw you in my brick and mortar, I would need an x-ray. Or if I saw you in my brick and mortar, I'd really need to listen to your lungs. And I can't do that right now. So I'm sorry, cancel out the visit for them. Don't charge them, whatever you want your policy to be. But in my experience, when I explain why I can't treat them, patients are understanding and all about it. Now, once in a while, you might see someone who comes on and it sounds like they have an STI, and you have to break it to them that, well, you need to be tested for everything. And there isn't one size fits all on an antibiotic. So sorry, but you have to go to the urgent care. They may roll their eyes and be annoyed, but I explained to them that, if they wait and if they did this with some other, other doctor who is willing to treat them, they should be worried about the quality of that. So, again, it's the education piece that's important, taking a few minutes to explain why telemedicine isn't the best place for them for that, but they could come back another time.
So good, strong, solid communication, right, is the key, which should be the key no matter how we're seeing them, right? Live or online. But yeah, this is wonderful. Can you talk about like maybe what are the top 5 diagnoses that you've seen that you feel the most comfortable treating online?
Worried about COVID, worried about COVID. Yeah, the worried well, right now, the worried well, although that has tapered off, was really bad in the beginning, busy bad, with just so many patients. But now I think, the most common thing we usually see online, hands down, is upper respiratory infections. So collectively, that would include your sore throats, your pink eyes, is it a sinus infection or just a cold questions. Allergies are a big one right now, a lot of allergic rhinitis. Why is it not going away, doc, with what I usually do? Things like that. UTIs are big, and in the summer we tend to see more. Of course, we only treat uncomplicated UTIs in women over the age of 18, and they can't have had one, recently. So we do have guidelines that we follow as a group, again, to preserve quality. I'm just checking my list so I don't forget. Oh, rashes. Yeah, rashes are always a big one, and I think I am skewed a little bit more to rashes because in my description I write dermatology as something I'm interested in, but this is the rash time of year, so we'll see people who are worried about Lyme's disease, we'll see tick bites, spider bites possibly, human bites, dog bites, you name it, as well as poison ivy, sunburns. This is what comes in. What is it? Is it eczema or is it psoriasis? So a lot of rashes. Women's health, a lot of just general questions about women's health. Perhaps menopausal women. Can I get your opinion on this? Could it be thyroid problems? So just a lot of face-to-face communication, fevers, and then of course gastro stuff, dyspepsia, maybe reflux, nausea, vomiting, diarrhea, constipation, those sort of acute issues. And sometimes, people will want a sick note, maybe they've missed work and they can't get in with their doctor, or they don't have a doctor, but they've missed 2 days and it really sounds legitimate, and we can provide them with sick notes for work.
Wonderful. And tell me, with COVID-19, when people come in and say, they want to get tested, what is your response there?
That is a long answer, because as we all know, it's not one size fits all. I think it's really nuanced to the person in front of you. What are they having symptoms or not? When did the symptoms start? Do they think they've been exposed to someone with known COVID-19, or have they not been exposed to someone that they know of has it but has had other symptoms? What do they do for a living? Are they a healthcare worker? Are they considered an essential employee? Are they staying home? Have they been home now for 2 months, which most most people, have been that we're seeing. Who's at home with them? Do they have people who are over 65 and chronically ill or immunocompromised? Do they have little ones at home? And what about their health? Do they have diabetes? Do they have any chronic heart disease, chronic lung disease, immunocompromised state? So really getting that patient to understand, okay, this is your individual risk based on what's going on with you, and then decide on testing based on that.
Okay. And then you're able to liaison them for testing as well?
So with our group, we don't order labs right now, and part of the reason is we are so large, we haven't found a wonderful way to have precise, consistent follow-up with the patient. So we're an urgent care model. Usually when we see a patient, what you see, and then they're done. Now, I am a staff doctor, which means I have regular hours, so I have the convenience of seeing patients back. And I love saying that in this time, I do have sort of my telemedicine patients, which is really nice. I don't even need to put it in quotes, my telemedicine patients, which is nice. So I do have a following, which is really wonderful. But so we don't order lab testing. What we can do is refer them to a lab, and we can help them find one near them. We have, obviously the test center list that we can, hone in on their zip code and give them recommendations. We can have them call local health departments to find testing sites and then give them a referral slip. Now, whether that testing site will use that slip, many are testing without orders anymore for the antigen testing, so that's fortunate, but we do the best we can.
Okay, but you will give an order if you think it's appropriate for that patient and they have an order from you. So that's
Correct.
that's extremely helpful. Yes,
Yeah.
thank you for that.
Yeah.
So for somebody starting out, what would you say first thing, what's like the focus? What's the focus if you're just starting out seeing patients virtually?
I really believe the first thing is your mindset. You've got to believe that this is a way to provide quality medical care, just like you're doing in the brick and mortar. You just need to get rid of that obstacle, because if you're resistant or hesitant or not all in or intrigued, at least, the patient's going to feel that, I think, and you're not going to have a successful visit. So you've got to mentally be ready and believe that yet you can do it. That's hugely important. And then I think the second thing is to know where there's help. You can call upon me. There are experts other than me out there who have had lots of visits. Call them before you go live and say, okay, hey, I just need a little primer, and can you check my setup? Or with a colleague, have a colleague call you through Skype and make sure that you look good, that your background is not distracting, your lighting is good, all of those checkpoints. Now, if you were to work with Amwell, just to give an example, we do have a test on your computer, button, so you can see how you look before you go live each day with your patient. You can check your sound, things like that. And we do have ways of doing sort of mock visits. So depending if you're doing it on your own or through a company like us, you can probably test yourself. But okay, I just lost my train of thought on that one. But yeah,
equipment suggestions?
Say that again, I'm sorry.
Equipment suggestions, equipment?
Yep, and equipment. Yeah, I would recommend that. It's so much easier to use a laptop and a monitor. The monitor will make the picture bigger for you, the patient will look larger for you, and your documentation will be bigger. If you work on, some of our colleagues like the ease of using a tablet or a smartphone. For me, with my eyes, it's really hard to do it all on this little thing. So I have used the tablet in emergency type of covering when I'm not in front of my setup, but a laptop with a functioning webcam, and as I have an external microphone as well as a speaker just to help augment that. I actually have headphones in case there is something like, the other day I had my husband mowing the lawn, I could put those on, things like that. So the more you do it, you'll realize how technology can really help make it such a successful visit. Yeah.
Okay, wonderful. I don't know, Melissa, do we have questions that have come in?
Just the one about resources up, and we just have another one come in. It says, how would you educate patients with fatty liver, sharing and explaining their lab results?
Okay, well, I would probably like to also get someone like Cynthia from Cape Farms involved in that one, because nutrition is going to play a big role in that. And so working with other resources, if you as the physician don't have time to take time to educate on, what their nutrition should look like, you want to have an affiliation or someone you could refer to, hopefully virtually, but you can do it any way you want. So you have that. What I would do at this point with that would be probably have my get acquainted visit with the patient, have them log in. If they already have labs and they know they have this diagnosis, they can upload those labs before we connect. They can either take a screenshot or they can upload a PDF file, however they're keeping track of that. Different platforms probably have different ways of showing that to the provider, but I can click on, before I click on the patient, I can click on the review button, and that will let me review anything the patient has uploaded for me before the visit. So I can already get familiar with the lab values and sort of know how I'm going to direct the conversation. They also can put in, their medication list, allergies, all of that. But again, I tend to reconcile all that just to make sure they haven't forgotten something. And then I would go ahead and click the connect button, and that's on our platform. It's a green connect button. And then again, greet the patient, make sure we can see and hear each other well, and then listen to what's on the patient's mind, and then go over everything that they've populated for me and decide, okay, well, what have you done in the past? What was your routine? Do you have a specialist yet or anything like that? And if they don't, then find a way to maybe get them, depending on the acuity, obviously, and how significant their results are. Do they need a screening ultrasound or a CAT scan? Do we need to keep looking at that? I can order those things for the patient, and then they would bring it back to me. Hopefully I'd have an affiliation with that radiology department that I'm referring them to, so they can electronically upload those results for me. I don't want to just get a report with their reading. I'd love to see the scan, things like that. It really depends on what you want as a physician. You can create your own rules with those sort of things. And then
I love this one in particular because it talks about using diagnostic testing within the visit, because I think that's one of the issues that I used to hear from physicians and say, well, how can I really get my diagnostic testing done and see? But you can do all of the same things you would do if the patient were live in these kinds of circumstances. I think that's the important message.
Absolutely, and I think that brings up a great point. The communication from the technology perspective as well. I mean, if you're going to order labs, you need to be assured you're going to get those results back to you, A, in a timely fashion, and B, the way you want them. Do you want them, to be sent electronically to you, which is yes, and you want to have it before the patient comes back. And then you should be able to schedule a follow-up visit with the patient when you want that. So really, see the difference? There's really not much difference than in the brick and mortar, other than I can't physically examine that abdomen if you want to measure out, your own liver size and that sort of thing. So again, it depends on what that patient needs. Now, for someone like that, if I was strictly virtual like I am, I would want to have a relationship with a gastroenterologist or a primary care physician who can handle this, again, depending on how severe the disease is, of course, that can do the hands-on part. But maybe they only need to go in once a year, or if they have a flare of symptoms. Otherwise, I can manage it virtually. Hopefully that answered the question.
Things you mentioned to me also when we were talking about, oh, sorry, Melissa, did you have
another
question?
A few other questions that are popping in as well too, Cynthia.
Oh, go ahead, please.
I did want to get to, we did have Angela. She asked, what video platform do you use or recommend? Do you use Zoom or something else?
Because I work with Amwell, we have our own EMR, it's like an EMR, it's our own video-based system. They run the software, they create the software, the coding, all of that internally. So no, Zoom has been allowed right now. Again, that's another regulation barrier that's been dropped, Zoom and Skype, but they're not HIPAA compliant. I don't think they're secure, so they're not really an entity we want to use within our company. Did I answer that correctly, Cynthia? Do you agree with that?
Yeah, that's fine. Right now, the question is obviously other people are doing Zoom and other modalities at this juncture, trying to get some continuity with their patients, and it is being allowed, as you said, and it is being covered. So I think that's the other message there, and they should look, and if people are planning to do long-term telemedicine in their practices, which I'm hearing from a lot of physicians, even though it's new for them, that they're interested, they should start looking at some of the platforms that are out there. And talking to their hospitals, because sometimes their hospitals offer some of the platforms and they haven't been involved with it. So
true. Yep.
Great. And then following up on that, Erin asked, are there any restrictions on emailing patients under HIPAA or any need for disclosure statements when emailing somebody who does not have a patient portal?
Yeah, I should have mentioned that. So at least within my experience, before a patient connects, they do go through the privacy guidelines and they check a box that they agree that any communication will just go through the Amwell system. So I do have a capability to secure, we call it secure messaging. It's not email. Again, email is not secure for your HIPAA information. So any PHI, you don't want to put through an email. And again, we train our physicians on that. So we have a secure messaging, which would mean if you had it on the app, you'd have to click onto the Amwell app. And then within that, you can secure message Dr. Mia. Okay, same with the email. If you just do it through the URL, you can then secure message Dr. Mia, but you can't secure message me outside. It won't go anywhere. So you want to make sure you are following HIPAA regulations and no PHI. We tend to talk internally with patient ID numbers. When we are having communications with quality teams and things like that go through email.
What about on the phone?
I can talk on the phone. I can share PHI on the phone with another physician and all, because there's no record of that and it's not being, taped or anything like that.
Okay.
Great. We have another question from Cassandra. She says, general nutrition education has been going well. She does say that when she has kids who have a G-tube, it's harder as she needs a height and weight to make decisions. Do you think that these types of visits should stay in person or can be virtual?
My feeling would be if you have capable parents who are, involved, they can get an accurate height and weight for you before the visit and can populate that in there. And then again, I would confirm it. If you want to see the weight, I would just make sure that the patient has a scale and you can physically watch them, get the child on the scale and look at the number yourself if you want to confirm it. But I would imagine that these patients are really good about giving you the right accurate information. They want their child to get the right formula.
Great. And then we do have a question from Linda asking about how does this work with DME companies or home supply companies? How do you, connect with them and make this sort of flow?
That's a really good question. We don't do that currently. The best that we can do is order. In our prescription order, we have over-the-counter prescriptions that we can handwrite, and they're blank. We can handwrite in, to ask the pharmacist to facilitate anything they may have in stock that the patient can get. But we have to explain to the patient that they're going to have to pay out of pocket. Insurance will likely not cover this, etc. It would be a great add-on, especially if you did a lot of, musculoskeletal, orthopedics, occupational therapy, physical therapy. All these different specialties are using telemedicine, workman's comp. I mean, these would be good places to have that capability. And I think it would be as simple as developing a collaboration with a company and then just developing the software workarounds around that, but it definitely can happen. I just don't have personal experience with that. Yeah.
Great. And then we have Amy. She asked, is the Amwell system connected to the health system's electronic medical record? And also, how do you prescribe? Can you send the prescription directly to the pharmacy electronically?
Yeah, we are not, we work with a lot of health systems, as you may know, if you have looked us up. We do not link electronically with them, which I think it would, ideally, that would be lovely to have. So we don't have access to the patient's health records. That's why we rely heavily on them giving us information and reconciling all of their health history at every visit. And as far as prescriptions, we do have capabilities of prescribing. We do have a limited formulary because it's interesting how we've chosen to do it. We really try to avoid drugs of any abuse, so we don't allow gabapentin prescribing right now on our urgent care platform. That is, chronic disease is a little different. Gabapentin, like tramadol, and any lifestyle medication, so ED drugs, we're not prescribing. Weight loss drugs right now either. And then certain muscle relaxants we have eliminated as well. We only have tizanidine and methocarbamol on our formulary, and I think that's pretty much the list right now. But yes, we can write a prescription. Can write a prescription so we can give, antibiotics for one example, to treat, acute infections. We can also refill blood pressure medications, anything that's a chronic medication. We just train our doctors to, not be overly open with refills. Now, during COVID. We just talked about this being a little bit more liberal with some refills because people are having challenges getting in. So if they're controlled, they've been on the same medication for years, go ahead and give them 3 to 6 months, depending on what the medicine is, of course. Same with cholesterol medicine, birth control pills, etc.
And Mia, just to clarify, you mentioned that you don't have a direct connection to the patient's record with hospitals, but you guys are partnering with about 2,000 hospitals in the country. So
Yeah.
can you talk a little bit about the relationships with the hospitals? Because I don't want people to go away thinking that you don't have hospital relationships, because
Oh.
that's sort of implied. And
Right. No, sorry, I didn't mean to suggest that at all. We have a very robust quality review team. So our quality team, and I'm one of the medical directors that works with the quality team. So every doctor is reviewed and is given a report card at the end of the month, just taking 5 to 10 charts. So it's not a big review. But out of that, we also will present things to our health system clients about the visits that have occurred on their platform. And they'll do the same. They'll come to our quality leader and say, hey, Steph, we're having this issue, or this is great, or what can we change here to make it better? Or we have, with those health systems, there's something called an insight tab that we have where the health system will tell us certain protocols that they want us to use. Let's say a patient has come in on that health system platform, but they don't identify themselves with a PCP. They'll have a number listed in there to get, or a website to give the patient, hey, we'd like you to follow up, in 2 weeks with this health system. Can you call this number or go to the URL, make an appointment for yourself, or at least get connected, and they'll take care of it from there. So that's sort of how we work with health systems. We cover their patients, we go back and forth with reviews and change things as need be, and they'll give us information that we have to disseminate to our providers about certain follow-ups and things like that.
Well, that's wonderful, because there's always questions and concerns from physicians who have not been involved in online medicine and telemedicine as to how the follow-up occurs, because that was the pushback that we used to hear a decade ago, that, okay, there's not continuity of care. The same thing
Right.
that, I hear as an emergency medicine physician. Obviously, that sort of depends on the practitioner as to whether or not there is continuity or not. So you're saying basically the policy is to have that continuity as much as
Oh,
possible.
absolutely. And I didn't finish, our whole walkthrough with the patient, but at the end of a visit, well, before the patient connects with me, I should say, at the end of the intake, there's an area for, do you have a primary care physician? Do you care to share the email address? And so at the end of the visit, when I submit the note, if the patient shared that information, a copy of the visit note will also go to the doctor electronically. Now, you know how things happen with technology. So I always, part of my closure for a visit is, please print off a copy of the visit note. It should be ready for you to look at it within 5 minutes. Bring that to your doctor next time you go. And if it's something that's really, that I think as a physician, I'd want to know, for instance, how many times have you been treated for strep this last year? If it's something like that, I'll say your doctor is keeping track of how many times you're on antibiotics, so please bring this in. Or, your doctor wants to know that you just had another UTI and you told me you had one 9 months ago. Please bring this in, let them know. So we really try to train our physicians to underscore the importance of that follow-up piece. Absolutely. It's a great point. I'm sorry I didn't mention it sooner. And there are a couple of larger health systems where we do have access to their internal records if we need them. That's a big lift because we're such a big group, but we do have that, which I think is a bright sign of what's to come in the future, where there'll be more open communication that way.
Well, just the uptick in utilization, you just mentioned to me, you just signed it on a new 116, or was it 160 physicians just recently?
Oh, just recently. So, we have a pretty big rolling credentialing committee. And yeah, over the last, I'll say it was just a week, we have over 100 doctors who are interested in getting credentialed with us and are going through the process. So I think what it shows is that providers in our communities across the country are, even if they're not necessarily going to add this on right away, they're interested in learning about it, and they're going through the steps to understand how they can successfully add telemedicine to their practice. And it's really wonderful to see. Lots of numbers.
Yes, it is. I'm very encouraged by it. I see the future of being, in office, maybe a patient sitting with an internist and being able to telemed the cardiologist in, or telemed the secondary, right? The
Yeah,
secondary
I mean,
practice.
How many times, have I seen in my brick and mortar, did I see an abnormal mole that I know it's not normal? Maybe I even already am thinking I'm going to biopsy it, but I don't want to biopsy it and ruin it. If I could
Yeah.
call in the dermatologist who says, oh yeah, Dr. B, just go ahead, do a full biopsy, and then send her to me with the lab results. There's just so many great use cases that I'm sure we all can come up with.
Yes, absolutely. Well, we're right at the end of the hour. Melissa, did we do pretty good with the questions?
Yeah, I think we hit on most of them. And if there are any outstanding, we can always send you an email with a follow-up answer as well, too.
Yes.
Yeah.
Well, wonderful. Mia, I just want to thank you again for your time and your enthusiasm. Such an important area for us all to become more familiar as both patients and physicians. We can, we can always do our continued learning and figuring this out, because we're all in this together during this time and in the future. Things are going to be irrevocably changed. So we know that there will be, I think, a growth of telemedicine that continues. And I'm very happy to see that. So thanks again. I really appreciate your time and all that you're doing for so many patients.
You're welcome, Cynthia, and thank you for having me here speaking about something that I truly am passionate about. And thank you everyone on the call for attending.
Okay. Thanks, everybody.
So long.
Bye-bye.
Bye-bye.